Good day, global citizens. Welcome to another episode of Dr. Fadimbola's Opinion. On this episode, I have a mentor, a mother, a consultant, someone who has ticked all the my experience with blood donation. Today, we're talking about blood donation in Nigeria on your paper on serovirulence, which is associated with blood donation in Nigeria. And since you're a top voice in blood donation in Nigeria, it's expected for you to be the one to bring on board. My experience on blood donation important. With regards to the paper, what we're trying to tell us about serovirus?
First of all, my career journey within the blood services, as you rightly said, started with coordinating the Blood Service Center in Abuja and also affiliated with Niger State and Nasarawa State that didn't have their own blood centers at the time. So working very closely with the zonal blood transfusion service in Plateau State, which covers North Central. And of course, being in there within the blood service, we had access to the data. So the way the blood service was structured is you have donors, intending donors who would come into the center. HIV 1 and 2 will be checking for hepatitis B, hepatitis C, and syphilis. If the result is out, do you want to know what the result is? Because this is part of, getting to convince people in our kind of Nigerian and African setting about donating blood. It's painful when a lot of that blood cannot be used for the purpose that it was intended because there's a reactivity for any one of these infections.
National Blood Transfusion Commission, do you feel Nigerians are receiving enough education and advocacy on blood transfusion and its benefits to us as a nation from government, non-governmental organizations, and private institutions?
Well, first of all, I know, Dr. Aziz, that you're quite biased. I was not the head of the National Blood Service Commission.
I thought you were the head of research.
Yes, I was the head of research, but when you stated it, you didn't mention the research. Unfortunately, it's not something that has garnered sufficient resources over the years. Not to say that if you had an inexhaustible source of funds, because there are other issues to contend with, like the cultural biases, which we'll speak to later, but at least so that we have a fighting chance towards building our blood donor base. At the National Blood Service, while I was there, one thing that was always said was any individual, the safest blood transfusion is the one that's not given. But that's not to say that there will not be people who will require blood transfusion. We know our statistics, road traffic accidents, pregnancy and childbirth, cancers, renal conditions, surgical procedures. Of course, that hasn't even got me into sickle cell disease, malaria, severe malaria with severe anemia. All these would require blood transfusion. So whether we like it or not, it is still a mainstay of medical therapeutics and interventions in medicine and surgery. So as part of trying to safeguard the lives of people who would need blood transfusion, we need to have sufficient blood units in stock, not just within the blood service, but also within hospitals that would be serving as transfusion establishments. A lot of the things that erode trust when we're trying to engage with blood donors is, oh, I donate this blood for free, but when I or a loved one has a need for blood, they are required to pay. Now, so those are some of the challenges because the service is, or the agency is, with a lot of progress so far, but still a largely unfunded part of the public health system. there's so many resources that need to go into that. So it's not that the payment is to pay for the blood in itself, because you can't even quantify what the value of that blood is, but the processing, the screening, the reagents, the storage, especially in an environment where we know what power generation is like. So it's even much, much worse than when I was there at the blood service because of the escalating prices of, generating power now. So that storage, even the training for the professionals who would be screening, who would be carrying out the processing, all those things cost enormous resources. And if we want to ensure that it is safe blood that is available for transfusion, those things are not nice to have. They must be had.
For each TTI, female donors had higher frequencies than males from the paper. Why do we have such deviation in statistics?
And translate effectively into lifestyle changes that can safeguard their health and protect them from these infections. So that female preponderance is not contrary to the expectation of the science. It was just particularly staggering that even in such
that I understand we have more work to do on women's health and generally the female population. And with people like you, excellent people like you, help tell people about the fact about blood donation and why they should stop getting scared about blood donation and any complication that can come from it. Dr. Oreh, please share your most touching blood donation story you've experienced and how it has shaped your work as a top blood donation voice.
So you can see that sometimes the individual may be linked to care, but at the caregiving establishment, once the price or the cost of that care is communicated, the person say, I was not sick, I just blood I want to donate. So I don't have this money now. I will just go back into society. So these are some of the things that we need to be looking at. There's this from the study we've done, and obviously from other research that scientists have done over time, there's a significant group of the general population who are infected, who will be touched at one point or the other to go and donate blood. And in the event that they turn out seropositive and are confirmed and require treatment, what plans are in place? And also render blood transfusions safe, but who bears that cost? And that's one of the things that we need to think about.
Thank you, Dr. Oreh, for elaborating on the effective management of those who are positive.
Families, patients will go and pay these individuals. But it's unsurprising that they had such almost double the TTI rates, seroprevalence rates in paid donors than in voluntary donors. And then see the replacement donors. Replacement donors, there's also a lot of potential for replacement donors becoming voluntary donors. You can see the safety profile. They were even less than voluntary donors. What that tells you is that oftentimes we, the relatives, we, the families, we, the patients, do the process of risk selection of, you might have 10 neighbors, you know the one you're going to call to ask to donate blood. So you've already done some risk stratification by yourself. So replacement donors are often not random. They are often carefully selected. You have 10 cousins, you need blood, you know all of them are matches for your blood. You know the one you're going to call. You know the one you're not even going to call, and you're going to tell the other, don't even call that one, no. And you know why. Because we are human, we know our people. We know those who we feel are risky. We know those who we feel are safer and more responsible. And so that is why there's prime opportunity to convert those replacement donors to voluntary donors, because there are already people who are leading somewhat safe lifestyles, known to their families, known to their communities. So imagine having more of them in the blood donation pool. It therefore translates to safer blood within the blood donation.